Hello, doctor. I can't hear you, doctor.
Sorry, hello, Dr. Kiwan.
Now I can hear, yes.
Sorry, I am in the car because I am going to Boston Children's because I am looking for some techniques and different things. But in a few minutes, fellow in Argentina begins to see your lecture. Can you give me 5 minutes or 3 minutes to?
Okay, I can wait, no problem. Just tell me when you're ready. I will stay online, but you
Okay,
let me know.
okay, thank you very much.
Okay, see you later.
Hi, Dr. Kiwan. Hello.
I'm back.
If you want,
Yes.
if you want to begin, the fellows are there in our room in Buenos Aires, and
Okay,
you can begin if you want.
I can begin. I can share my. Can you introduce the group to me before I go? Just
Yes,
give
yes,
me a
of course.
summary, please. Yeah,
Yes.
just go ahead.
Uh,
Yeah.
my group is a pediatric cardiac surgery team that we work in Buenos Aires. We did every year approx 500 cases per year, and we have a residency and a fellowship at our hospital, and your lecture is part of our program for our fellow because we are always thinking how we can improve different techniques and different treatments. And I know you have a very good new tools and new treatment in cardiologists, and this is an example of we are looking around the world. Thank you to be there and to give to us your knowledge with your lecture.
Okay, so the people they all are fellow surgeon, pediatric surgeon, or cardiologist, combination and mix up, or
Our people is cardiac fellows, cardiac surgery fellows,
surgeries.
surgeons, exactly.
Okay, there are no cardiologists in the group now.
I don't know, probably no. I sent to the cardiologist the link, but perhaps now in Argentina it's a very busy time. But perhaps it is. I want to invite now other cardiologists, but the team is listening you now, and they are waiting for your lecture.
Okay, so my lecture is regenerative cardiology. They know that, yes?
Yeah. Perfect.
Regenerative, not intervention, not
Okay.
surgical.
Okay,
All right.
that will. Yeah.
Okay, I will share my screen. And now, can they hear me now?
Yes, I listen you very well, but I didn't see your presentation.
It's not shared because I shared it down in the group. You don't see the slides?
No.
Okay, then maybe I need to minimize. What about now?
No, I see you. No, the slides.
You can't see the slides, yeah?
Exactly.
Okay. So can I start if everybody is seeing my slides?
Yes,
And can they see me video or no?
I didn't see. I didn't see.
Okay. A bit because I'm sharing my screen, then they should see me. What about here? Share link to this slide.
Do you see at the down level the share, the icon share?
Yeah, I'm looking for that, but the icon has disappeared, and I click on the share, but let me see here. I can see you. That's what I hate, this technology. Anyway, they can hear me or not?
Yes, very well. I listen you very well.
Okay, then probably it is better not to see my face, then only focus on my lecture.
Okay.
I don't know what happened. I don't know where is the icon, because here, before it was there, and I click on it on share the screen. Anyway, can I start?
Yes, you when you want, but I didn't see the slides.
Ah, the slide gone. Before you said yes.
No, I didn't see the slides. Never I saw.
You never saw the slide.
Yeah.
Although I clicked on share, which is screen, then this one, share. I have the icon share. You should see me by now.
Yes. Now, yes. Great.
Do you see the slides?
Exactly. I see very well.
They are in full screen or partial screen?
Partial now.
Let me go full screen and see. I am in full screen. I can see you and you can see me, correct?
Yes, very well.
Technology is working. Okay, buonasera, buongiorno, or what do you call good morning?
Good morning. Good morning.
Good morning. Okay, so I will introduce myself. I am Yahya Kiwan, Fellow of American Board of Regenerative Medicine, Fellow of American Board of Cardiology. I am interventional cardiologist, so I compete with you, and we do a lot of intervention. I have done many intervention in pediatric age group, which is pulmonary valvuloplasty, aortic valvuloplasty, PDA occlusion. Nowadays, I'm actually adult cardiologist, but I have some pediatric experience and training as well. Now, today I thought I will not talk intervention or surgery. We'll talk about a new science, this science called regenerative cardiology. So this is my publication on a review of stem cell therapy in ischemic heart disease, and published a year ago, which is a review of literature on the application of stem cell therapy in all cardiac diseases. Can you hear me, yes?
Very well. I listen to you very well.
Okay. So what are the application of stem cell therapy in cardiology? We can use a stem cell in post-myocardial infarction. We can use in ischemic cardiomyopathy, non-ischemic cardiomyopathy, intractable angina. Cardiac surgery include pediatric and adult cardiac surgery. And because you are pediatric surgeon, I might stop here. There are new application, although mainly animal study, but also on clinical application in humans of using stem cell therapy in aortic valve disease, and especially in pulmonary valve implantation, especially in hypoplastic left heart syndrome, pulmonary stenosis, and aortic stenosis. I will come to that later on. We have application in congenital heart disease, and we have application in microvascular angina. Now, talking about stem cell therapy, we have to know, do we have evidence? Are we talking sense? Are we talking nonsense? Are we talking science or no science? Now, according to a recently published systematic review, there are more than 1,138 clinical trials have been registered on clinicaltrials.gov, of which 60% are phase 2, phase 1, and phase 3 clinical trials, and more than 500 trials published with bone marrow as a primary source of mesenchymal stem cell in most of clinical trials. And remember, all the trials, this is important talk, that all the trial reported safety of stem cell therapy. Cell and all these more than 500 trials is very safe. Now, the other point, I mean, is it effective or not effective? Now, the conclusion of this trial says, irrespective of cell type used, the stem cell therapy approach is undoubtedly superior to current treatment approach in addressing the repair of the injured cardiac cells to limit the vicious progression of the disease process. And it compensates for the loss of functioning cardiomyocyte. So there is a repair and replacement of any lost or damaged cells in the body or in the myocardium. That's very important start for my lecture. Now we go to the application one by one. We have post-myocardial infarction, and this is the literature. I will share with you this meta-analysis of randomized control trial published in 2024, very recent. And this shows that they reported 79 randomized clinical trials of more than 7,000 patients. And what result we have? They followed patient up to 36 months, which is more than 3 years. There will be reduction of mortality, reinfarction, and stroke. There is also improvement in left ventricular ejection fraction. So this is in post-myocardial infarction patient, more than 7,000. How about in a patient with heart failure? This is also a recent meta-analysis of 2024, published recently. And this is the title of the study, Efficacy of Mesenchymal Stem Cell on Major Adverse Cardiac Event and Cardiac Indices. This is a meta-analysis of randomized controlled trials. What we have 17 trials, including 1,684 patients were enrolled and looking any effect of stem cell on mortality or on rehospitalization. As you could see, significant improvement in mortality, the p-value 0.04, and the rehospitalization p-value 0.008. Improvement in left ventricular ejection fraction, improvement in its systolic volume and diastolic volume, and above all, decrease in the scar size. So the fibrosis of the heart is improved with the stem cell therapy. There is also improvement in the NIHA class, the 6-minute walk, and the conclusion that intracoronary dose of stem cell therapy 100 million or less was effective. Talking about non-ischemic dilated cardiomyopathy, another meta-analysis of randomized trials using of stem cell therapy in more than 600 patients of autologous bone marrow cells injected intracoronary. And as you could see, there is improvement in ejection fraction and diastolic volume and in 6 minutes walking distance. Now, any effect in refractory and stable angina? This is another randomized meta-analysis of controlled clinical trial published in 2019 by Jones et al. And he randomized more than 8 controlled trials of more than 500 patients looking for a primary endpoint of MACE, mortality, anginal episodes, anginal class, exercise tolerance, and anti-anginal therapy. And you could see here the results are excellent, where stem cell therapy improved the angina class, has improved exercise tolerance, has improved ejection fraction, decreased anginal episode, decreased the use of anti-anginal medications by patients, improve the perfusion defect, and above all, improvement in mortality. So better survival for people who receive stem cell therapy. Now we move into tissue engineering, which is, I think, a very important part, and especially in congenital heart disease, and especially for pediatric cardiac surgeon, cardiac tissue engineering. So in cardiac tissue engineering, we have many techniques. This one of the technique called autologous skeletal muscle cardiac patches. So a cardiac patch is created with a stem cell and patched directly on the myocardium. Now, the purpose of this study is to see the effectiveness of autologous skeletal cell patch implantation for non-ischemic dilated cardiomyopathy. They involved 24 patients with non-ischemic dilated cardiomyopathy, and they put a patch directly, autologous cell patch directly put on the myocardium, implanted by surgeons like you, and here we could see the result. There is improvement in symptoms of the patient with cardiomyopathy. This is the New York Heart Association symptom, improvement in the walking distance of the patient, and both are significant. Okay, another I think a topic which is very important for you as a pediatric cardiac surgeon is the use of decellularized heart valve performance. So I will go with you. The topic says that clinical performance of decellularized heart valve versus standard tissue conduit, a systematic review and meta-analysis. Now, the background, we know that valve replacement surgery, especially in pediatric age group, is usually the definitive management strategy for patients with severe valvular disease. However, the valve conduit currently in clinical uses are associated with significantly. So a tissue engineered decellularized heart valves are an alternative prosthesis that have demonstrated promising early good results. So the purpose of this systematic review and meta-analysis is to perform a robust evaluation of the clinical performance of these decellularized heart valve implanted in either the outflow tract position, and, especially in the pulmonary outflow tract, treating surgical treatment for congenital heart disease. So the primary endpoint looking for post-operative mortality and the reoperation rate. And I think the reoperation rate, in my opinion, is more important because, as you know, with pediatric age group, you might need to perform 1 or 2 or 3 repeat surgery when the child grow up to change the outflow tract or the conduit or the pulmonary valve and so on. So what they reviewed 16 clinical trials were included. In this clinical trial, 1,400 patients underwent outflow tract reconstruction with the decellularized heart valve, and 2,700 patients received standard tissue conduit, which you normally do as a pediatric surgeon during childhood. Now, this is the result. The result showed there is a lower post-operative mortality. However, there is more reoperation in the conventional group, and the group received a decellularized valve were satisfactory and statistically significant difference between the two groups. So the conclusion that using this type of decellularized valve is superior to a usual current surgical technique. So decellularized heart valve implanted within the right ventricle outflow tract have demonstrated significantly lower reoperation rate when compared with standard tissue conduit. Now, I think exosomes, I might pass that. What about the use of growth factor therapy for angina? Again, this is a new era in the regenerative medicine treatment for patient who is on maximum anti-anginal therapy, but without any significant benefit. This is another meta-analysis of use of growth factor, and the result of 16 randomized trial of more than 1,600 patients, there is significant decrease of the major adverse cardiac event, significantly improving the angina, but there is no significant difference in mortality. What about gene therapy for angina? Uh, Again, there is a trial called EXACT, a phase 2 trial. In this trial, they used gene therapy for refractory angina in 32 patients and looking for exercise duration and exercise tolerance after 3 months, 6 months, and 12 months. As you could see here, the patient who received stem cell therapy has better exercise duration compared to patient who did not receive. The myocardial perfusion scans are much better improved in patient with stem cell therapy. And the anginal frequency also decreased in patients who received gene therapy. Now, this is which I want to go through with you. This is a new fellowship in regenerative cardiology. The American Board of Regenerative Medicine has just developed this fellowship, and this fellowship is called, fortunately, under my name, which is Kiwan Cardiac Regenerative Medicine Fellowship, KCRMF. This is actually a double degree, which is a diploma in general medicine and general surgery, and fellowship degree in cardiology. And what are the eligible for that? This is actually a cartoon where I'm planning when I retire, I will open a coffee shop. Instead of calling Starbucks, I will call it STEM box, and hopefully we can sell stem cell like coffee. Now, if you allow me, I will minimize this and I will go quickly through my fellowship slides. So these are the modules. Is it okay?
Yes, very well, very well.
Give me 10 minutes, then we will discuss. Is that all right?
Very well.
Thank you. Okay, so these are the modules of this fellowship. We have first the diploma, and in the diploma, the modules and the lecture will focus on history of regenerative medicine, basic science, the biologics in regenerative, and then clinical science, which is cardiac regenerative medicine, pulmonary regenerative medicine, endocrine, hematology, and tissue engineering and gene therapy. Now, these are the course director, which you don't need to know them. I am the chairman and course director, and these are my colleagues. I will go quickly. So what are the modules in regenerative cardiology? We have basic science modules. We have pathophysiology of cardiac regenerative medicine. We have cell-based therapy in cardiac regenerative, cardiac tissue engineering, gene therapy, evidence-based review by disease condition. We'll talk about post-myocardial infarction, and especially we have also modules for cardiac surgery in adult and pediatric age group. We will discuss also the types of stem cells used in our course, and you could see this is the list of the stem cell used in cardiology. We will also talk about how we inject stem cell to the heart, either intravenous or intracoronary or direct myocardial or direct surgical technique through cardiac surgeons. Also talk about gene therapy, RNA therapy, and growth factor therapy. We'll talk about, this is important for you, of cardiac tissue patches. We talk about bioprinting. We talk about artificial tissue valve, decellularized, especially in pulmonary outflow tract and congenital heart disease. We'll talk about gene therapy in vivo, in vitro. This is the most important part of the fellowship, actually. There will be a study by disease condition. So we will present evidence of real cases from cath lab where we do stem cell therapy in patient with ischemic heart disease, with angina, microvascular disease, post-myocardial infarction, and congenital heart disease. So you are a pediatric cardiac surgeon. We have modules on hypoplastic left heart syndrome, modules on pulmonary stenosis and aortic stenosis treated with stem cell therapy. We also have a role in adult cardiac surgery where we use a stem cell in the aortic positions and also pulmonary valve scaffold. We also have a visit to a laboratory producing stem cell. So you will have a practical exposure to stem cell, how it is harvested, collected, cultured, banking, and how the stem cell transported from the laboratory of stem cell to your theater, to hospital, or to cardiac surgical places. The course is every 4 months, and it is online course, which is like virtual lectures from your place. You can review the lecture, and every 4 months, there is a physical 3 days course review and examination in Dubai, United Arab Emirates. We do the exam every 4 months. Thank you for listening, and I am open for any questions, any discussion, please.
Thank you, Dr. Kiwan, for your presentation. I like a lot. Thank you a lot. I have some questions, but I don't know if any fellow or anyone has a questions in the room. Please go away. I don't know if there are any questions. I have some questions for the
Yes,
beginning. One is how you decellularize the homograph.
Yeah. How you now basically the homographs are taken from either pericardium or other valvular tissue from other places, and not we call it like allogenic from other person. Now this tissue or the connective tissue or the valve tissue will be decellularized completely in the laboratory, and this decellularized material will be manufactured into like a tri-leaflet valve in the pulmonary position or in the aortic position. So there is no cell on this mechanical valve. However, this mechanical valve will be injected with the growth factors and other materials so that when it is uh, put inside the pulmonary outflow tract or in the pulmonary artery position, it will attract the endogenous circulating stem cells from in the body, and it will gradually grow into all the cells type in any pulmonary valve or aortic valve. So it will grow endothelial cell, blood vessel, connective tissue, nerve cell, and so on. And after 12 weeks, almost, the valve become totally cellularized and functional as if a normal pulmonary or aortic valve. But the important thing, the cells are endogenous cells. They are attracted from the circulation, the stem cell from the circulation, and converted by itself multiple, which is constituting the current tissue and connective tissue and smooth muscle and blood vessel already in any valve. I hope I was clear.
Yes, very well.
Yes. Yeah.
And yeah, yes. And
Yeah.
do you know how long is the reoperation with this kind of decellularized homograph?
You mean how long it take to prepare it?
No. When you use in the operating room
Yes.
this homograph, do you know the time to change this homograph in how many years works this
Yeah, okay. I don't know the exact, but I can tell you because the study which I showed you, 3,000 patients, they compared
Wow.
normal valve to
Yeah.
an decellularized valve. And at the
Yeah.
time of follow-up, which is, I'm sure, years, they found you need to reoperate more on the normal valve or normal
Okay.
conduit. However, the decellularized valve, they live longer, and the rate of reoperation is much less compared to the normal technique which you are doing. I don't know the follow-up duration.
Okay. 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 And about the cars that you give, it is very expensive. Do you know the cost of this course?
The course.
Yes,
You're talking about the course.
exactly. Do you know
Okay.
how much
I
is
know.
the?
Yes, I know. I tell you, it is run by the American Board of Regenerative Medicine. And
Yeah.
if you like, you can write down, please, the website. It is
Yes.
www.kcrmf.com, which is Kiwan Cardiac Regenerative Medicine Fellowship.com. So KCRMF.
Okay.
Now, all the details of this fellowship is written there. However, if you like, I can tell you, I am expecting that there are 3 parts of the course. There is a course online, which is around $9,000. It ran for 4 months. It's in Dubai, which is 3 days. This is $1,000. And there is examination fees by the American board. I think this is about $4,500. So probably the cost is maybe around 15,000, running every 4 months. But for more detail, go to my website and it will explain everything there.
Okay, thank you, Dr. Kiwan. I don't know if someone has a question. If not, I want to say to you, thank you very much for your time and your knowledge. And we keep in touch to perhaps to do things together.
For sure, we will, and I will. You are with me in the group, yeah? And
Yeah.
LinkedIn group. You will get all the information, advertisement, and course outline on my group. If you want to add more people, please send me. They can join. They can ask for to add, and they get a lot of educations for free on the LinkedIn, regenerative cardiology specialist group. And the launch of the course will be in August. So in August, you will get more details about the course. Hello? Hello? Hello?
Okay, I can't listen to you. I don't know if
Can
you
you hear
listen
me
to
now?
me, but say goodbye. Bye-bye, and thank you very much, Dr. Kiwan.
Say bye to Messi. Hello to Messi.